quality of the connections. So it was really, really impressive.
That's great. Thanks.
Welcome, everyone. Thank you for joining us. We're glad you're here. I think we'll give folks a few minutes to file in the room.
And
For those of you that are just joining us, welcome. We're giving people a little time to file in the room. Good to see some of you, and of course see some of your familiar names. Hey, Kristen.
Good morning, Mark. How are you?
I'm pretty good.
Great.
Kristen, are you going to want to say, or could you say anything about the CTN meeting that's coming up?
Sure. Our annual CTN Steering Committee meeting is next week, April 24th through 26th. And I can put the registration link in the chat. It'll take me a minute to find an email, but we encourage anyone to attend. It is in person or hybrid this year. There are virtual options to listen to many of the sessions. So we welcome you to join in.
Thanks, Kristen. Well, I think we should get started. Good morning, good afternoon, wherever you are. I hope there's some signs of spring. I can tell you I was in Vermont last week, and in 1 square yard there was snow and mud and grass and crocus, and I guess in Vermont that's definitely a sign of late winter, early spring. Temperatures ranging from high 30s to low 80s, all in a day or a week's time. So I hope wherever you are, there's same signs of hope and optimism for the what's next. And also I think we got organized enough to have a presence at the CTN Steering Committee meeting, this one, but I think that's something that this group should talk about. Maybe the next one, maybe there's something we can do. It would be great to convene this group, face to face. It would definitely add to our connections. Really happy that a newer but a colleague of mine whose work I've noticed over the years, and I think has been making really important contributions to our field, has straddled kind of effectiveness and implementation research. His work has always been impressive for its public health relevance. It's not just a line or two in a grant application that says this one will have public health impact. The kind of work that Dr. Aalsma has been doing clearly has that kind of front and center in the mission, and you know, I think scientific rigor can contribute to that. But I know the prime motivator is actually improving the care and outcomes of youth who are often involved in the criminal justice system. So Dr. Aalsma is at the University of Indiana School of Medicine. He's a professor in pediatrics. He's been at this for a while. His work has been funded by NIDA at R1 levels. He's also involved in the HEAL initiatives in a few different ways, working together on a HEAL Data to Action initiative, which is really kind of sparking innovative projects using data to inform key decision makers on how they're doing on metrics like overdose death to overdose rescue to providing medication-assisted treatment to opioid prescribing as well. So it's a really interesting collection of projects. And Matt's a great colleague. I think you'll enjoy what he has to talk about. I think for those of you that aren't implementation researchers, Matt, you know, can bring the perspective of how you can also make the work you're doing much more in the realm of implementation research as well. So, Matt, welcome. We're glad you're here from the middle of the country. Thank you for joining us.
You bet. Yeah, I love the allusion to hope with spring. It does feel hopeful with sun coming down, and it does get fairly dreary in middle America during those months. So great to be here. I'm happy to be here as well to talk about adolescence. I'll talk about some of the unique features of that time period, that second decade of growth where there's so much going on. I've got a 15-year-old at home who's grown 6 inches over 6 months. Can you imagine that? I can't imagine that. I think it'd be sore all the time. He was crabby a lot. Maybe that's why. But so many changes. We see them externally, but internally as well. And I am a part of this group, so the Adolescent Behavioral Health Research Program. I'm dropping some information in the chat. So 9 researchers tackling from kind of T1 through T4, T5 with adolescent mental health, addiction, all the rest. So keep our group in mind with all of your great work. And then I'm going to be talking about a project associated with the J-Coin initiative through HEAL. So improving justice to community partnerships, 13 hubs within that network. There's a description in the chat of the program. And then there's a resource called JTAC. Amazing podcasts, videos on medications for opiate use disorder. There's a training on mixed methods research, implementation science. So I would encourage you to look at that JTAC resource, distribute widely. I've never heard anything negative about the resources that are there. So please use that resource. I'm going to go to shared screen and would love for you to interrupt me, for you to ask questions, all the rest. How is that looking? Are we good?
We're good, Matt. Thank you.
Good. So here's the title, Adapt. So this is what we're calling the project, really looking to improve the uptake of evidence-based treatments as well as practices. We'll talk about the distinctions within that. So here's my context. Right? We all have a context. The opioid crisis has definitely been an issue here in Indiana, and we're particularly noticing that with young people right now. So the adolescence is the age group where overdose deaths has raised more quickly than any other age group for the last couple of years. Indiana now is tied 5th for overdose deaths, and with Kentucky, with Ohio, who have been hit harder with this whole epidemic. And we know that rural jurisdictions are struggling more in this realm. And then we in Indiana have some difficulty with access to behavioral health care treatment. So we're really trying to innovate at a state level to look at telepsychiatry, telemedicine, really getting evidence-based services to the young people that need it, and adults for that matter, in any way that we can. And today I'm going to be talking about justice-involved youth, but I want to highlight this program. So this is a part of some of the statewide training work that we've done on Met-CBT. We have an ECHO article that I put into the chat as well, focused more on medications for opioid use disorder. But we know that these trainings that many of us do, many of you do on the call, sometimes maybe this is just an Indiana issue, have a hard time getting community mental health centers to the table. And that's not because they don't care. It's because they have competing demands. Billable time, such a huge issue. The referral stream. So we do this great training around substance use treatment, but perhaps there's not a referral stream for patients to do the training. Are they going to be practicing them? They don't get a referral for 6 months. You just lost all that time that has been there. And then our leadership, are they bought in? Are they ready to do this? And a lot of these issues are implementation issues. A lot of these issues are culture. A lot of these issues can be addressed. We have to acknowledge them, name them, and have a plan of how to address them. I'm trained as a juvenile forensic psychologist. That's where a lot of my work has been. Young people in the criminal justice system have very high rates of substance use disorders. Youth in the general population, about maybe 10% by the time they reach 18 will have a diagnosable substance use disorder. We're looking at closer to 50% for youth involved in the criminal legal system. Treatments work for everyone, for adolescents, as long as it's evidence-based, but are they getting that evidence-based treatment? Probably not. National research has shown that to be true time and time again. And then substance use is just a consistent predictor of recidivism. When we're doing a forensic psych eval for a young person that comes through our system 2 years down the road, 2 years down the road, usually what we notice is that problematic use has escalated to a substance use disorder, and then it's kind of continues this trajectory into adult recidivism. So you want to try to stop this cycle. It's a really important one. One of the things, and feel free to hop in with any questions during this time, and I'll try to monitor chat as well. One of the things that we know in the juvenile legal criminal justice system, which is true for the adult system as well, as we tend to have kind of polarized systems. Sometimes we have community mental health, juvenile court that work well together, but in general, there's a different culture, there's different norms, there's different demands on time. So we need to really acknowledge that and then plan for that when we're talking about a hybrid trial, for instance, looking at effectiveness as well as implementation. In general, we found in doing work across the state and across the nation is that the court system generally feels like community mental health don't hold clients accountable. They're too soft with their recovery. CMHCs, on the other hand, feel like the juvenile justice system are punitive, more so than needed, and really need to think through all of these issues. So we want to think about what can we do to depolarize some of these issues, particularly around the substance use care cascade, which we're going to be getting into in a couple of more slides. If you haven't done as much criminal justice work, in general, the justice system, particularly the juvenile side, is fairly flexible. They can shift if they think it's important. They're fairly autonomous, less demands with billing, obviously. And there is an incredible focus on diversion in the juvenile world right now. So diverting youth away from the criminal justice system. That has been true with the adult system due to COVID, but now we're starting to see some of those diversion efforts kind of come down. We know that that's going to be an important issue that NIDA, all of us are interested in, is how to divert really well, divert to treatment. On the behavioral health side, we have formalized processes, an emphasis on patient privacy, super important, but has some implications when we're talking about cross-system collaboration, and retaining individuals in care and treatment. Again, very good, but they have to worry about billing. They have to cover staff time. This is a very important issue for them that sometimes the court system doesn't quite acknowledge. So how can we address this care cascade issue when you have systems, a cross-system partnership that are sometimes polarized, some kind of butting heads. So that's some of the work that we've been doing over the last several years across the board. I really enjoy this quote from a juvenile court probation officer. CMHCs are like battleships. The JJ system is like a speedboat. They can shift, they can navigate fairly quickly. While CMHCs, they have a billing, they've got that structure. This is how it happens. Maybe there's a policy change, but it's hard to turn the ship. So I think that's a nice example of what we might be butting into. And then for therapists, very open to doing evidence-based practice, but their time is limited. We have some community mental health systems that are incentivizing some of that change, some not. The funding requirements are very significant. So you know all of these issues, they impact your work on a daily basis. This has led to our ADAPT project, so statewide learning health system, reducing substance use. We're emphasizing some of this work in more rural to moderate sized counties, having a partnership between the treatment as well as the court systems, looking at data, all tackling that substance use care cascade. I always smile when I see this study figure because we paid $1,500 for it. And I'm not sure it's worth it, but we're going to use it all the time. So I'm going to get my money's worth out of that figure. Okay, substance use care cascade. This came out of the HIV literature. We know that there are all these individuals with HIV in the community. They're not going to be identified unless they're screened. We know that there's some issues with screening, who gets referred, who gets engaged in care, who's actually taking medication, 100% adherent, CD4 counts going down. So each step in the cascade, we're losing individuals, which impacts the work. This is applied to substance use care cascade as well. Now, in this example, just like in other cross-system work, we have the justice system owning that front end. Who's getting screened? Who's getting identified? Who's getting referred? We have the community mental health treatment providers owning this side of it, the behavioral healthcare system. Then we have this black kind of box in the middle. So who's helping with peer navigation? Healthcare workers, are there technology ways to help engage? So that black box is where many of the projects in JCoin have been tackling. If you go to JTech, that website, you're going to see some really great examples of using peer recovery coaches within probation, within jails, to really help address that connection piece. So our goal is really to improve access, use of evidence-based addiction treatment, reduce dropout, really to bump up all the way along. So you might be wondering, how does this apply to the work you're doing in the CTN? A big part of this is we don't just want to have young people go into care, we want them to go into evidence-based care. And another piece of that is, where are we getting that dropout and how can we maximize those referrals, which again, I think has significant application with some of your work in the CTN. We're using a learning health system approach. So learning health system been used in hospital settings for the past decade or so. We're bringing it out of that hospital setting into the community. And that means looking at local data to see how can we amplify that cross-system collaboration. So we're working with local partners for them to review their own substance use care cascade data, for them to generate local tailored solutions to address those gaps. As a part of the training that we do with counties, we give them a list of evidence-based practices on the juvenile court side and treatments on the behavioral health care side of things for them to use the best evidence possible with their tailored solutions. So that's provided to local counties to inform their work. And then conduct continuous quality improvement as they're innovating around screening, referral, engagement, the handoff. Is it working? So looking at local data to see if it is working. This is really thinking about applying implementation science to the CTN. Here is the implementation science approach that we have used with this project. It's called the EPIS model. So Greg Aaron's one of the consultants on this project. This is his baby, but it really gets at a number of issues to really think about when we're thinking about providing evidence-based treatment. Do we have state system support, funding, infrastructure? One of the things that we have been learning is around diversion. It's difficult for community mental health centers to pay for treatment when a youth is completely diverted from the court system. That's led to some local state work around providing resources to pay for services when a youth is diverted, because we want that to happen. That means you don't have probation officers looking over a young person. If they do screen positive at a drug test, then to violate probation, get them deeper into the system, going to divert as much as possible. What is the organizational support like with this alliance? Do we have senior leadership buy-in? What's the culture around the use of evidence-based practices? We need staff support. And we are solidly in the implementation phase right now. So the learning health system, looking at evidence-based interventions, practices, treatments, and we're going to be entering into the last year of sustainment. And then at the bottom, you see the implementation strategies that we have used at the exploration, preparation, implementation, so doing the work, and then at sustainment. I would definitely recommend using an implementation science model that fits with your work. We have a very staged approach, which is one of the reasons that we went with the EPIS model. It has informed our work and been something that we hang our hat on and that we talk about regularly. We have a stepped wedge trial. So we have 3 cohorts, the green, red, and purple, that have been brought into the project. These county names you don't need to remember. And that state is Indiana. That's where we're at, right underneath the Great Lakes, for those not in the know, on the coast. But we have some really small counties. So Pulaski County, there are 20,000 people in the entire county. So they're bringing perhaps 60 youth into the justice system on a yearly basis. In Marion County, Indianapolis, in the middle of the state, for instance, we have 1.2 million people in the county. There are 5,000 youth arrested on a given year. So very different. But Pulaski has one of the highest overdose rates in our state. So there is desperate need for services. You don't need to as well to know the names there, but we have them up there to recognize the important work they're doing. And everyone in yellow are new. So over the past 4 years, we've had incredible churn within the workforce. You all are experiencing that, I'm sure, as well. And that just means doing this work gets more complicated. So this data-driven continuous quality improvement approach really looks at looking at local data, tailoring those solutions to local needs, because each county has their own resources, better or worse partnerships that can be relied upon, and then really thinking through how they can tailor some of these solutions. An important part of this is data visualization. So this is where I'm going to nerd out for a little bit on the research side. And this might be less applicable on your end of things, but if we're really thinking about where young people are getting lost to care, we want to understand where they are, and how doing that visually can be really impactful at a local level. This just shows the different data systems that we've had to work with around our probabilistic as well as deterministic, so exact matches of young people. Centerstone is the largest community mental health center in the nation. We have about 24 counties that use Centerstone. We have some very small ones. So 4 counties are in, surprise, surprise, 4 counties in Indiana, hence the name, 4 county. And then we have different community mental health EHR systems. So Avatar, Streamline, Acumed. So I'm not sure for your settings what systems you're using, but each of them have benefits, negatives, and then we have different JJ systems as well. This is to show the complicated nature of doing some of the data linking. Initially with our counties, it took about 3 days to do the data linking per county. We are now at the point where it takes 5 minutes to do this data linking. So we've really automated it. And we're thinking about how to sustain some of this work at a state level, because counties feel like it's useful. We're going to be looking at effectiveness in the next 12 to 18 months. We use Tableau as the data visualization framework. really looking at who's getting referred, who needs treatment. This is at the very beginning for some of our sites where they just weren't screening universally young people coming through. So if you're not screening, you're not identifying, you're not referring. So that was a best practice that most of our sites tackled. And then we looked at the number of days between events from a referral or arrest to getting screened. Now, 37 days, some of us are wondering, how could it be that long? Well, for some jurisdictions, it might be a paper referral. They don't come into intake until day 30 to meet with the probation officer, and that's when screening happens. So we've been trying to work with counties, and what they really tackled as well is reducing the number of days. Because for anyone, for a young person that gets arrested, they don't hear from probation for 2 months, they're thinking this is not a big deal, right? So if there's arrest, if there's communication, if there's diversion, it is more impactful for young people. And I want to emphasize that we're viewing all of this data through an equity lens. We know that disproportionate minority contact is a significant issue for jurisdictions across the nation. And we have definitely seen that in the engagement side. So we find that screening in general are identifying fairly similar rates between white, African-American, Hispanic youth. But then that engagement, we see incredible disparity, or particularly for African-American youth, they're not engaging in treatment at the same rate as white youth. And we wouldn't know this data if we had just community mental health center data. We wouldn't know this incredible gap if we had just juvenile court data. It's by bringing these two together that we understand where that loss can be. And that's where we've seen more disparity evident across the board. Here's a more recent data visualization that our sites were asking for, looking at who's getting screened, who's not being screened, looking at average over time. And then here's the last one that one of our sites up north suggested, and all of our sites are really appreciating this one because it shows the different pathways to care and the different ways that a young person can be lost to care. So this Sankey diagram is one that local alliance teams have been using more and more because they would like to get young people into that top line where they're getting referred, initiated, and engaging in treatment across the board. So for our alliance teams, they're finding the data to be useful. And we've done more innovation on that side of things. So let's get to care, right? So working on best practices, we're finding that jurisdictions are finding this information to be helpful. Over the last 3 years, 2.5 years for some of our cohorts, we found an incredible amount of interest in brief interventions. So T-Intervene is an intervention for youth with mild to moderate substance use disorder. This is one where we have peer recovery coaches, caseworkers, individuals without that licensure that can provide an intervention. And a lot of our sites like it because it's task shifting. It saves up the time for a master's level therapist to see the youth with more severe substance use disorders. We've also been training them on MET CBT across the board. So 27 therapists so far with 9 months of supervision. We use Listen for our fidelity tools, so an AI tool out of Seattle that monitors the use of MI. That was definitely a barrier with some of our sites around privacy concerns, but incredible team that really has worked with us and worked with local sites to help that happen. And the screening process is one that's really informed the work at a local level, and that's fundamental to any of our work. But it's identifying more young people that need that care. So finding that uptake with evidence-based fidelity has been good for these two interventions. And then we're going to be moving into more evaluation effectiveness mode for the next 12 to 18 months. So thinking about your work in the CTN, thinking about the fantastic work that you're doing to really bring more evidence-based treatments to individuals that really need it. A big part of all that work is leadership buy-in. So we can hear the right thing from leaders, but are they willing to not only say the right thing, but have their behavior match their words? So are there resources to allow staff to miss 2 days of billable hours to get that training and evidence-based treatment? Are there incentives built in when fidelity to that model has reached a certain level to keep people engaged? We have some agencies that are worried to allow their staff to get that training and evidence-based treatment because they may leave the community mental health center and go open up their own shop. We see that happening all the time, and we understand that worry. So talk with leadership about how to incentivize training that helps with staff staying in and helps with them being more engaged. And we've learned some of this from qualitative interviews that staff are more willing to stay even with lower pay if they feel like the work is valued and it's being incentivized at some level. Identifying a champion. So who's going to really champion this work? For our alliance work, it's a community mental health person that really views this addiction as important. Most individuals getting into working with children and teens didn't necessarily want to do addiction treatment. So we've had to work with some of the stigma that's around some of these issues. But with training, with supervision, with addressing, we've seen champions really able to engage and help that work continue. The quality improvement plan, do, study, act cycles has been helpful to measure impact. So when they see the screening rates going up, the referrals going up, initiation improving, particularly for youth of color, we get more buy-in from local sites. So that's been a helpful process with this all. And then of all of this work, we really want to think about how can we sustain it. We know the model of the train and pray. So do a 2-day training, hope that people do it. It's not going to be enough. We hope for spring, we're glad for that, but we need to do more on the evidence-based training side. So that's an incentive to leadership, changing systems and practices to improve that uptake. And that incentivizing is where we're really starting to think about more, how can we work with settings to help that come to fruition. So on the implementation side, we found that it's really helped us engage with systems more and really measure that culture change over time. And in the coming months, we're going to be able to get even more information on all of this work. So I really appreciate your time in thinking through some of these issues. I would definitely encourage everyone to check out the JTech resources, spread those widely. Many of them are focused on medications for opioid use disorder and partnering with justice partners. But anyone doing work in addiction knows that's the primary referral partner. So how can we really think about that system and engage even more? All right, 30 minutes. That's my talk. Would love to have any discussion, questions, thoughts, comments. Thanks so much for your time.
Thank you, Matt. Downside of virtual meetings like this is that you can't hear the applause. It's unfortunate. But I'll open it up to the group. Well, Tessa has, I guess that's an applaud. That's nice.
And I saw Reed. Thank you. I saw you.
That's right. Silent applause. All right, people are jumping in. So that's awesome. Well, let's open it up for questions or comments. I know I have a couple, but I'll turn it over to my colleagues to jump in at will. You can raise your hand or just jump in. Either one is fine. It's a small enough group today.
Matt, that was a terrific presentation. Thanks so much. And amazing work you're doing. I'd love to hear more about the feedback you're getting on the dashboards and how different communities or counties are using it. And also to hear from you and others on the call or in the meeting, how you're approaching or successes you've had with leadership buy-in. What are the convincing arguments, or not arguments, but data or approaches? Thanks.
Thanks so much. Appreciate that question. Dashboards, they're everywhere, right? So everyone has a dashboard out there on overdose or COVID. More and more states have them available. The reality with many of these dashboards is they're not really used, or maybe they're glanced at, or we feel good because data's out there for the public, but is the public really using them? So that's where we really worked with end users in terms of our justice as well as community health partners. And one of the benefits of looking at data is it takes some of the negative energy out of the room. So instead of these discussions about, hey, I referred Sammy to you, you never called back. The agency's like, what? We never got a call from Sammy's parent. Well, yes, they recall, so these fights that we have, instead you can look at data. And as long as the data is trusted, right? So that's fundamental. If the data isn't being entered correctly in the EHR or the juvenile court system, then that's going to be a problem. But as long as people believe in the data, it takes a lot of that negative energy out of the room. And then you can start talking about solutions. So I think that's the benefit of this data-driven approach. And then in terms of the leadership buy-in, it's huge. And just having the state tell local community partners that they have to do that, oftentimes it's not enough. So maybe you have to find that partner that's, maybe it's the CFO that's really making a lot of the decisions in that community mental health setting. Maybe it's that supervisor that's been there for 30 years that's really driving that. So it's finding that leadership and bringing them to the table. And I too would love to hear from anyone on the call about ways they've been able to engage leadership and lead to some of those changes. So thanks, Kristen. Any folks that have really found great success with that leadership engagement side of things? Or horror stories? Lawsuits can be helpful, let's be honest. Now that's a road that most of us don't want to go down, but that's really changed the practice of many jails across the US around medications for opioid use disorder. So sometimes that can drive some of that change. It's not the best carrot.
Yeah, I think it does tap into some of the questions and comments I had, Matt. And first of all, remarkable presentation and really remarkable job at engaging all these systems. And I know people I mentor often say to me, how do you do multi-site work as an early career investigator? So I think there's probably some wisdom you can impart there. How is it that someone from a medical school can engage disparate counties across the state of Indiana in a project? It takes something, and probably leadership on your part or your team's part, to bring people to the table. So I think any thoughts you have about that would be useful. The thing that jumped out at me, and having worked in the field for a little while, is the idea that community mental health centers would be at all interested in treating people who have a substance use disorder. Most community mental health centers don't do that. In fact, primary care is more likely to provide medications for opioid use disorder than community mental health centers are. It's really a sad situation. The integrated care is not as common as you would think. So I'm glad you touched on some of the stigma and issues around community mental health center clinicians taking on people with substance use disorders, particularly those that are complicated with developmental and criminal justice involved issues. So that the fact that you do that seems to be pretty extraordinary. And maybe Indiana is different than a lot of other places across the country, but Battleship is both a battleship in terms of cumbersomeness, but also with guns, like don't come near us kind of thing. So that, I guess there's that question, and maybe a third question is related to the step wedge issue, and sort of thinking about, oh yeah, we noticed in our first leg that Blacks were less likely to be retained in treatment. And so, whoa, that's really important. And then you have the second and third kind of legs joining, or waves joining in, and you think, well, maybe we can learn something in terms of our implementation strategies to improve the chances for Black youth making these connections. And if you do that, how could you not deploy those strategies, for the second and third waves? But in doing so, you sort of tinker a little bit with the integrity of your trial, if it is a trial. And I think we always try to, what's the external, internal validity, what's the public health impact versus the scientific rigor. And I, for one, would always lean in the direction of doing the right thing. So I guess I just want to know how you grappled with that. So that maybe that's too many questions. I think there are 3 in there. Let me know what you think about those.
Yeah, that's great. So it does help that I have been in Indiana for 23 years. I know, Mark, I don't look that old, but I am. But really, so I think, and then being as responsive as possible with local partners as well as state partners. So when I get a call from a probation officer or anyone in the community about the care of their child and wondering about resources, I'm returning that phone call in 1 minute because we're a trusted partner. So really being as responsive as possible with state and local partners, then they feel that engenders trust. And we do evaluations at no cost on a local diversion program, even though it's taking resources that we have because it's important to our partners. So I think all of that goodwill goes a long way. On the CMHC side of things, we do see higher rates of stigma towards adolescent substance use for community mental health master's level caseworkers compared to juvenile court professionals, which is for a lot of our partners are really surprising. But again, I think it goes into CMHC want to work with mental health, not addiction. Juvenile court recognizes most of the young people coming through their system are using substances and they need services. So we actually find lower rates of stigma in that setting. And that Met CBT article that I mentioned there, it was funded through SOAR funding. And we actually provided community mental health centers $50,000 per site to allow their staff to get out of billable time. And that still wasn't enough for many of our partners. So it's not just money. It needs to be an issue that they see as valuable. And yeah, I think we all continue to battle that one. So when we have a local site that wants to innovate, we bend over backwards to provide training, to provide resources, trying to lift them up as an exemplar for other community mental health centers to emulate. And working with Centerstone has actually been very positive for us. So their national headquarters is in Nashville, and they have a lot of reach. So we're hopeful for that partnership. And then lastly, third one on the stepped wedge piece, we have that tension as well, Mark, is so I think that's where we're really encouraging local sites to look at their local data, because, for instance, the differences that we're seeing with young Black youth engaging in treatment, that's a very local issue. We're seeing that be amplified or lifted up more as a negative with some sites than other sites. So I think that's where having the local data is incredibly informative, because then it's their data. What do you want to do with this? How are you going to address that? And we're not addressing it through the research piece as much. It's more local alliance partners. This is your community. How do you want to deal with that? And most of them are coming to the table in really big ways. So I think I answered your question.
Yeah, no, impressive. Thank you for even remembering all of them. I realize I gave you a lot to chew on. Other thoughts, comments?
Maybe I have like a more simple-minded question, but I think, first of all, like really, really nice work. And I really respect the way that you brought the different partners together and the way that you've been able to bring their data together, which is a whole another set of challenges.
Yeah.
And so my question is really like, just for your data visualizations, those are such a great tool if you can get people to look at them and if they make sense intuitively. Who does those for you and how do you pay for it? And like, how should we think about that and building it into these types of projects?
Wow, that is a big one, Jennifer. So with our latest project that Mark was alluding to, we actually have partnered with a data visualist, and that is his job as an informatician. We are also, that's one of the reasons that we're using Tableau, is it's a free program that most of our juvenile court and CMHCs have access to, or they've actually used on their own already, which was surprising to us. But I think this is where some of that learning health system, most CMHCs are doing quality improvement work and looking at some of their own data. So I think Tableau is a really great one. And we're definitely willing to share any of the visualizations that we've worked on. But those that you saw, those were done by my team that aren't data visualists. So it's just kind of standard data visualizations that our folks came up with. The new data visualist PhD, we'll see if those get a lot more fancy, but it's still going to be within Tableau. So I think Tableau is a really nice tool. We'll be writing this up, so we'll make sure to have Mark send some of the data visualist work out to you all. Thanks for that question. Yeah, and let me just say, data use agreements, it's quite painful, let's be honest. So when you work with local counties, we're going to be doing more work at a state level with a group that is called Management Performance Hub in Indiana. Their focus is on linking data and developing data dashboards. They sit in the governor's office. This is a resource that not as many states have, but most states have someone doing dashboards, whether it's Department of Health, Department of Mental Health and Addiction. So they do all the data use agreement work. Praise God. So, I mean, I think that's where we get into a lot of the issues, and is when we have legal coming in, and as they should. It's data they should protect very closely. But we're excited to have some other folks do that hard work.
Hello. Really great presentation. Thank you so much. And I agree with what's been said, that the visualizations were super helpful, especially I love that treatment cascade that you had. And I was wondering what you would identify as some next steps for you and your team in terms of like thinking about well, any next steps, but also looking at the disparities in engagement, and if you have identified any ideas for addressing that, or if you see that more as like a local level. Yeah. Thanks,
Tessa. Appreciate that question, comment. Next steps for us are to think about, for sustainability purposes, is this something that we can work with our state partners to help own on the data use agreement? We can support them on the data linking side. And this is one of the issues in Indiana, is Department of Child Services or Child Welfare for our state. They pay for all of the mental health and addiction services for youth on probation. So since they're paying for these services, can they help on the data linking side? And then can we use a system called system of care? So each county has a system of care. Can that be a framework where you start building some of this work in for sustainability? Super important question, Tessa. So we're still working on that end. And then on the disparity side of things, we have two fantastic professors in our group, Tamika Zapowski and Tisha Riley. They have a equity grant through NIDA, and they're working with local counties on some local solutions. But I think that is where it falls down, is the local part. And we really want to lift up local teams to do this engagement work around equity. And we're finding that they really want to do that work when it's identified as a local problem. I think it gets a little bit harder when we have the state come in and make people do things. At least here in Indiana, county government really wants to do what they want to do. But if we can help support local and have local solutions around some of these issues, and it doesn't have to be a culturally adaptive treatment, although I think that is really important. It could be just a transportation issue. So let's understand, is that what it is? So yeah, thanks, Tessa, I appreciate that.
I think Matt, we both have a common colleague who has a methodology, the stages of implementation completion, and I think we've referred to that methodology with this group. It's a way of tracking really participation in a project. And I know with work that we do, multi-site work that we do, there's a wide variation in the degree to which, our participants actually participate. And yeah, we think that that's pretty important. So I guess, you mentioned your counties and how diverse they are. They're really a subsection of a larger group of counties in the state of Indiana. So won't talk about how you got who you got, but in terms of, keeping the group together and bringing them together, are there particular engagement strategies for these counties that you feel that have worked better? And maybe if you can share those, I think those of us that work with an N of organizations or an N of sites could really benefit from knowing what are the kind of things that you've done that you found helpful.
Yeah, I do think it is being, again, responsive to state partners. So SOR funding helped pay for the Met CBT. We have a whole ECHO training program that Department of Mental Health and Addictions has partnered with us. So that's really helped kind of that statewide reach. On the juvenile court side of things, I think that's where I'm working with state partners on policy, data, really being responsive to local needs, so then they know who we are. I also do a police officer training that many of our counties have done, simply to be out there locally and help lift up this as a needed program. So I think all of that has helped with some of our reach across the board. And the SIC, so Lisa Saldana's tool really is helpful to look at some of those local changes. And I think that's where we would like to lean in more, so look at that. And our counties were actually chosen because they're in the top 50% for overdose rates across the state. So we reached out to them based on their need, and they really responded. And they were also top 50% with poor access to behavioral health care. So they were all struggling in those two areas.
That's impressive. Normally it goes the other way, where we support the people that probably need it less, the volunteers, the well-resourced. So that's really impressive. I didn't get that from your presentation earlier.
Well, I didn't say it, so that's why you didn't get it. So that was my bad. And we've actually had probably the most robust engagement from our 4 sites with the poorest access and highest rates, because they notice it at a local level. They're feeling it with young people and their needs. So they've been very responsive.
That's really awesome. I think we have time for one more question.
Well, I have a question, Matt, and thank you so much. It was a really wonderful presentation. My question is this: I guess it's kind of a philosophical question, is what's the role of coercion in managing addiction problems?
Yeah.
It seems to me we need some sort of integration of the drug court, recovery court, juvenile justice system, and a better system of healthcare if we're ever going to get ahead of this. I'd just be curious about your thoughts on that.
This is such a huge issue. Thanks so much, Reed, for lifting that up. It's a significant issue and often a barrier to treatment. So a young person is court ordered into treatment, probation officer says you have to go. There isn't necessarily an increase in that engagement for that young person. So I think that's where the more that we can train intake probation officers in motivational interviewing and have them really help that young person and the parent, when we can get them engaged. Parent engagement is a significant issue and barrier to treatment. Then we see better engagement, not just engagement as going to 3 sessions, that's how we defined it, but actual engagement, talking about issues and all the rest. So I think it is a significant issue, barrier, and we want to think about how to do a much better job. I think in general, some of our court systems are doing better They're recognizing that just because they order it doesn't mean that it's going to happen. And we're seeing more jurisdictions across our state and nationwide with parent youth advisory boards. So individuals with lived experience trying to help that court system. And this is obviously a huge priority of NIDA. It's obviously something that we all recognize that we want to do a better job of engaging stakeholders. Then we get to those outcomes that we really want to hear their voices. So thanks, Reed.
Thank you.
Well, thanks everyone for joining us. Matt, that was awesome. And I hope, for some, it's the start of a conversation. I know you've been generous and you talked about, being responsive and building trust. And I think all of my interactions with you are definitely along those lines. So I think whatever you're doing, it's, it's really, kind and human across the board. So I think people can contact you, for further information. Elaine, we usually keep these slides available and we archive them, so they'll be accessible. So thank you for sharing those. Our next meeting of the SIG is in June 20th. And I'm excited that Aaron Lyons, who's at University of Washington, has agreed to present on human-centered design. And I think, we all struggle with, how to incorporate our end user, whether they're patients or providers' perspectives in developing our interventions, in developing strategies or adaptations to those interventions, whether they need to be changed or modified, or whether we need to do special things to help providers to use them. And human-centered design has been around. I don't know that it's been applied as systematically or scientifically to our field as it could and should be, but Aaron is kind of leading that effort along with several others, really applying the best of that kind of engineering to the kind of work that we do. So we'll send out some announcements. I think Aaron is really looking forward to presenting to this group. I think those of you that are implementation researchers will appreciate it. Those of you that aren't and are more intervention developers and evaluators, I think will also benefit from hearing what Aaron has to say. So I think we're good. Thanks, everyone. Enjoy the rest of your day. And a special thanks again, Matt, for leading the discussion and sharing your great work. Bye, everyone.
Okay.